Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to Remission Possible, the podcast dedicated to guiding and supporting you on your mission to achieve low disease activity. We understand this challenge wasn't something you asked for, but remember, you're stronger than you think, and you deserve the opportunity to regain control and live your best life. In this audio guide, we'll talk about what suboptimal disease control means for doctors and patients, and specifically how participating in shared decision-making with your doctor can help you find the treatment to achieve low disease activity and fully participate in day-to-day life. This podcast was created in partnership and sponsored by AbbVie. All guests were compensated for their time. Joining us today are two expert rheumatologists, Dr. Meese and Dr. Ogdi. Our conversation will be based on the patient-centered findings of two recently published abstracts about psoriatic arthritis and axial spondyloarthritis from the European Alliance of Associations of Rheumatology, or EULAR. Whether you're in the early stages of your disease journey or looking for inspiration and motivation, this audio guide is for you. So join us on this mission as we help bring you closer to achieving better disease control and enhanced quality of life. Let's get started.
Let's begin by defining what is suboptimal disease control. I work with patients with a variety of rheumatologic conditions, including rheumatoid arthritis, psoriatic arthritis, and other diseases. And these are characterized by chronic inflammation, meaning immune cells gathering in various tissue sites in the body and causing inflammation, which leads to pain, but also tissue destruction, for example, loss of cartilage and bone around joints. When I first entered rheumatology, we were actually using weekly injections of gold to treat rheumatoid arthritis, quite a medieval kind of approach. We've so advanced our ability to control the disease process and put it into a state of low disease activity or even remission. This is something that I could not have imagined earlier in my career. But now that it's possible, this is what we want for our patients. In order for them to be able to get back to a relatively normal life, back with their family, back with work, ability to function without pain or stiffness. We have found that many patients may treat their disease for a period of time and then may lose control of their disease, may have moderate or severe activity, kind of like a fire that is suddenly roaring out of control. This is not what we want. We really want to strive for a state of low disease activity on a continuous basis so that we don't have any tissue destruction, joint destruction, and this is what we want for our patients.
That answer sheds a lot of light on what patients might be experiencing. Let's dive deeper into that. Dr. Ogdi, how do you explain suboptimal disease control to your patients?
So I don't think many people know or use the term, and I actually don't use the term when I'm talking to patients. But patients will come in saying, I don't think my drug is working as well as it used to. I'm starting to have more symptoms, or I'm having flares more often, or I'm having a flare now. So there's different terms that they're using, or I'm just having more pain and more swelling, and so on. And so how do I talk about it with them? I will talk about it with them in terms of what are the different features that they have that are active. And then sometimes I'll say these are inflammatory versus not inflammatory type symptoms. And so we can target them in these different ways. So I usually point it out in terms of at the end of going through the history and the exam saying, so this is what I see today. I see 3 swollen joints and your ankle is really hurting you and you're not walking as well. So I hear your function is a little bit decreased. You're not sleeping as well. You're a little more tired. So it sounds like the disease is more active and we need to make some changes. And then I'll kind of break it down into how we're going to move from there. I also pause there to get their reaction to that too and make sure that the patient agrees or see what they want to add.
I like that process. You make sure the patient has the opportunity to share how they feel.
I want to always make sure that patients understand there's inflammation and there's areas of symptoms that are not inflammation. One of the more common ones that's not inflammation is fibromyalgia. And about 20% of our patients with psoriatic arthritis or axial spondyloarthritis, 20 to 30 even, have some form of fibromyalgia, which is a syndrome of pain all over, pain that just kind of persistent throughout the day. It doesn't really get completely better. They tend to have disrupted sleep, sometimes trouble thinking, for example, and really severe fatigue, or the fatigue tends to stand out for people. So switching therapies isn't really going to help with that. So that needs to be treated separately. So I think it's always important to think about when we're talking about suboptimal treatment, that some of it's not really suboptimal treatment of the inflammation, it's suboptimal treatment of the patient who has another condition that needs to also be treated.
Dr. Ogdy and Dr. Meese presented 2 similar studies at EULAR. One focused on axial spondyloarthritis and the other on psoriatic arthritis. Both studies looked at patients who started taking TNF inhibitors, tracking their symptoms and disease activity over 6 and 12 months to see if they respond well or not. So let's get back to you, Dr. Ogdy. What about those that didn't respond well to treatment?
Among the patients who didn't respond well, we kind of looked forward in time for the next 6 months and found that most of them still didn't respond well. So I think some of the take-home points from this set of abstracts is if you're not doing well at 6 months, things are probably not going to change much by 12 months unless you make a change. Starting with other things up front, like physical therapy, weight loss in the scenario that someone is obese, because we do know that obesity prevents people from getting to that low disease activity level. So if we can start with that more comprehensive treatment plan up front, I think that would prevent us from getting to that place where you're not hitting the mark at 6 months. And then at 6 months, if things are really not going well, making changes to not still be there at 12 months.
Great, thank you. And Dr. Meese, can you please give us your perspective on these studies?
Dr. Ogdy and I are both investigators in a registry in the United States known as the CorEvitas Registry. In this registry, we collect data on patients with diseases such as psoriatic arthritis and axial spondyloarthritis. In this particular set of studies, we ask a simple question. In patients that were being treated with TNF inhibitors, what was the outcome of their treatment? Were they in a state of minimal disease activity, which is a criteria in psoriatic arthritis, whereby we assess joints, skin, enthesitis, pain, patient global, physical function. And if the patient has achieved a very low level of disease activity, then we say they're in a state of MDA, or minimal disease activity. There's a similar threshold in patients with axial spondyloarthritis, which we call the BASDAI-50. This stands for Bath Ankylosing Spondylitis Disease Activity Index, and at least a 50% improvement of that measure. And that takes into account things like patient pain, physical function, and so on, similar to the MDA in psoriatic arthritis. What we were dismayed to find is that the majority of patients being treated with TNF inhibitors at either the 6-month mark or the 12-month mark were not in a state of MDA or BASDAI-50 response. I say dismayed because our goal in treatment for these conditions is to get the patients into a state of low disease activity so that they can have normal lives. I think it's important for clinicians to understand this, to assess their patients on a regular basis, and really strive to do what it takes with medication adjustment or physical therapy or other approaches to optimize their outcomes.
Great. You've given us a lot to think about. Dr. Meese, why is it important for a patient to learn about studies like this? And how can this research help them better communicate with their doctor?
Caring for patients is a collaborative process. It's a dialogue between the patient and their clinician. The decisions about treatment should be shared in that conversation. And so it's very important for patients to know what is it that we are striving for when we use medications to try to control inflammation and active disease. When we're partners in that process, it improves the chance for better outcomes. And thus, I think it's really important for patients to know and understand what it is that we are striving for as clinicians when we're trying to get the patient into a state of low disease activity or remission.
Thank you all for sharing your insights and experiences and for giving us a true and honest picture of what it's like to cope with uncontrolled disease and how to work together as a patient and provider to reach a better treatment option and quality of life. And to our listeners, thank you for joining us on Remission Possible, the podcast where we explore the path to low disease activity and improved well-being. We hope the stories, insights, and guidance we shared have inspired and empowered you along the way. If you've liked what you've heard, be sure to rate our podcast, write a positive review, and spread the word by sharing with your family and friends. It'll help more people like you find us.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.